do the clinical presentation, so I'm gonna let Ern to take over.
All right, so I'm just going to share my screen for our presentation today. All right. Can you all see my screen okay?
We can, thank you.
All right. So, as Kamal mentioned, this is our team for our wellness program. We do this every second Friday of the month. And today we have Erin on with us. She is co-hosting with me. She is one of our other dietitians on our team, and we're going to be talking about fad diets and diabetes management. So, fad diets is something you might have heard the phrase fad diets before, but it's really just a big umbrella term for just diets out there that might be popping up here and there. They are what you call a fad, they're short-lived usually. So today we're just going to kind of talk about what's a fad diet, how to identify it, why it might not be appropriate for our diabetes management. And then Erin is going to help me identify certain types of fad diets that you might see out there, and then we'll kind of wrap it all up at the end. But what is a fad diet? So a fad diet is a trendy weight loss plan that promotes dramatic results. They're based on very little scientific evidence and share pretty much the following characteristics that you see here. So quick fix, promotes some magic combination food, something to melt belly fat, or you see those advertisements listed all over social media and things. It does exclusion diets, so like heavily restricting certain nutrients, claims based on single studies, or emphasizing, one food group over the other. So that fad diet usually is pretty extreme. You'll normally see it's usually one side or the other, and it's pretty rigid for the most part. So why don't fad diets work? Right? We often don't recommend some of these diets that we're going to talk about soon. But we want to talk about why they're not the best option. So the biggest thing is limited scientific evidence. So fad diets are often backed by very little science. There's issues such as eliminating certain food groups, removing essential nutrients from the diet that could cause any kind of deficiency. Nutrition is a science, and so a lot of our recommendations are based off of heavy scientific evidence and research. So we don't want to be doing things that could impact our body that haven't really been studied, researched, or know that it's not going to be dangerous or harmful to our body. We often see that these fad diets are a one-size-fits-all, giving you a specific calorie range for everybody, a specific eating pattern for someone, a window of eating that's going to fit you, right? But it doesn't look at you as the unique individual. Every single person is metabolically, different, right? We need to have individualized eating recommendations for every single person, which is what us as RDs do. We work individual case-by-case basis to find a way that makes sense for you, that works for your body. We often find they're also unsustainable. So if you look at some of these dramatic plans that we'll talk about, they're usually unsustainable long-term with, if any, short-lived benefits. They may have, one thing in common that they recommend doing this thing so that you get this benefit, right? This big benefit. Sometimes it's weight loss, sometimes it's improved lab work or things like that. And normally it might work. You might see some improvement, but it's unsustainable. So you can't carry it out your whole lifetime. So then we end up seeing those benefits drop off if there are any. It actually does, to kind of go into these patterns of fad diets, harm your metabolism. When we restrict things, right, we go back, I think we've talked about it many times before in these sessions, it hurts your metabolism, right? So you go into this kind of scarcity. Your body thinks, nutrients are scarce, so it's going to slow down your metabolism because you want to hold on to everything you can get because there might be a famine coming, right? Where there might be another diet. Your body kind of gets that rhythm over time. So it can do harmful things to the metabolism. And it might regain, you might have some rebound weight gain too that comes from these fad diets. When you kind of yo-yo diet, you'll see that yo-yo weight gain. or you might, gain all this weight back, maybe more than you even, had before, after doing some of these things. And that yo-yo weight gain can cause increased risks of cardiovascular disease, disordered eating thoughts and patterns. So it's important that we don't kind of go in this direction of yo-yo dieting, going into these fad quick fixes, because they can be pretty harmful to your system. And then you get into the restricting key nutrients. When you take out a whole food group, you're losing all the vitamins, minerals, beneficial things that your body needs. So there could be some severe nutrient deficiencies. And there are certain diets out there that you might choose to, change a lifestyle pattern. Like if someone wants to go vegan, that's perfectly fine, because they have, certain convictions about animals or things like that. But then we want to take a closer look. Are you meeting your B12? Are you getting certain vitamins and minerals and missing out on certain things? Because then we can supplement for them. But then we don't want to just go on a diet willy-nilly and not take account for those vitamins that could be missing, those nutrients that could be missing. And we don't want to be so reliant on supplements that we're missing all the good things that come from food, because really the food first approach is how we get the best absorption of those nutrients. So then why are fad diets harmful for our diabetes management? We see that some weight reduction does help with our diabetes management. So why wouldn't a fad diet that, helps us lose weight be beneficial? Fad diets don't take into account your unique carbohydrates, sugars, or basic nutrition requirements that you need to function each day. So there are a lot of low carb, keto diet, things like that, that heavily restrict carbohydrates. But the recommendations actually, I think it's a minimum of 130 grams per day. Your brain actually needs 130 grams of carbohydrates a day to function properly. So that is a recommended daily allowance that they put out there as well, or 45 to 65% of your calories should come from carbs. It's your body's preferred source of energy. And just going and restricting that could do some harmful things. And it could make your blood sugars fluctuate. And we really want to take that approach in going into, diabetes counseling with us, that you learn to, not fear carbs, that carbs can be helpful. And there's quality over quantity, right? We can talk about the quality of carbs that we eat rather than just a specific amount. We can talk about what is going to benefit you in the long run and be sustainable too. These diets often offer temporary weight loss benefits, but most are unsustainable. In the next slide, we'll see kind of a cycle, the diet cycle that, a lot of people have gone through. It's you kind of get in that rebound weight gain cycle too, like we talked about. When you restrict your nutrients, your body goes into the scarcity mindset of I have to preserve, what I have. And we don't want to drop weight really fast, gain it really fast, because that can be harmful on our body. Restriction-based fad diets can increase your cravings and binge eating behavior. We find a lot of the time, especially if you're restricting certain nutrients during the day, you're going to crave those at nighttime because your body is trying to, catch up from the day of not getting enough to eat. But you could also have, I know, food noise, right? I've heard that technical term too, of feeling, food obsession, or things, I'm thinking about food all the time. And it mostly comes from a place of restriction. We're restricting heavily, either physically or mentally, for the foods we can and can't eat. So going into those fad diets could put you in that restriction mindset, which could cause you to binge later on, and eat, tenfold of what you would have eaten if you would have just had a balanced meal. So that binge eating behavior can negatively impact your blood sugar levels because, you'll get a spike, or maybe you're not eating enough and then your blood sugar plummets. So we don't want that blood sugar fluctuation, and where we could have had avoided that if we would have just had consistent eating patterns through the day. So we want to make sure we also don't go, we'll talk about some fasting and things like that, but we don't want our blood sugar to plummet, jump up, go back and forth. There's even parts where if you don't eat, for long periods of time, your liver compensates, right? Your liver is going to release extra sugar into your system to make sure you're getting enough. So your body has this built-in little safety net here to make sure that you're going to stay alive, but we're constantly fighting against it. And these fad diets don't necessarily benefit us for our diabetes management. So this is the little cycle I was talking about. about the vicious diet cycle, right? We have a diet, we go into this famine response where we lose weight from lean muscle and fat, right? So we maybe are taking from muscle too if we're not eating enough. We have a reduced metabolic rate, increase in fat storage, and then we fall off because it's unsustainable. But then we go into a feast response. So reduced metabolic rate, loss of muscle, regain of weight from fat, right? So we're, constantly eating because we weren't getting enough beforehand, and then we repeat it. But there's also a psychological aspect of these too. They really, really weigh you down.
All right. So with the Diabetes Wellness webinar, we've been doing this for many years now as a platform to provide additional resources and information about a variety of topics. We have PCPs as well as specialists who attend to talk about things like endocrinology, cardiology, nephrology, podiatry, physical therapy, as well as many other topics. Again, with the goal of discussing how diabetes may affect these other systems and how the other systems and diseases play a role in the patient's diabetes. So on our next slide, again, these are our panelists for today's discussion. And our discussion today is really a new topic for us. We've not previously discussed it here on our wellness webinar. So Joseph's going to be talking about management of diabetes in patients with Alzheimer's, and Ern will then discuss brain healthy foods. So with that, I'm going to go ahead and turn it over to Joseph.
Hello, everybody, and welcome to the presentation today. I can see the screen. Donna, are you going to be moving the slides today?
I will be.
Oh, okay, great. Thanks, Aaron. All righty, so let's get into just a broad definition of what we're going to be discussing today, specifically as it relates to diabetes and Alzheimer's disease, but also the relationship between diabetes and dementia as a whole. So first, let's get an idea of what we're dealing with diabetes. We have type 1 diabetes, which is our autoimmune diabetes, where our immune system attacks the pancreas, it doesn't release enough insulin, and the cells aren't getting enough glucose because insulin is responsible for the uptake of glucose or sugar into our cells. Today, really, we're going to be discussing type 2 diabetes, which is a very prevalent condition here in the United States. Type 2 diabetes is caused from something related to insulin resistance. So we're getting that insulin from the pancreas, but the cells aren't properly adequated or up to date with the insulin as they should be. They're not responding well to the insulin. As an effect, what happens is we have blood sugar circulate throughout the body more than it should because our cells aren't taking it in like they are supposed to use for energy and other biochemical resources as well. So that increases the blood sugar in our bloodstreams and leads to the effects that we're going to see. Insulin resistance, though, is not just due to diabetes. It's also due to being overweight, being inactive. Obesity plays a big role in this as well. And so let's establish our definition as well for dementia before we move on. These two, the insulin resistance, diabetes, will play into the effect and risk factors of dementia. Dementia is an umbrella term. So Alzheimer's is one form of dementia. There's many others like vascular dementia, frontotemporal dementia, Lewy body dementia. We have our Parkinson's, Huntington's. Today specifically we'll focus on Alzheimer's, but dementia is basically an impairment in memory and cognition. Okay, so we'll go to the next slide here. So what do we know already? We know uncontrolled diabetes and high blood sugar that's in the bloodstreams like we talked about can damage our nerves, our neurons, and our cells, and also our blood vessels. So if we damage our blood vessels, well, our blood vessels, we use them to transport oxygen from inside and outside. Oxygen is taken up by the cells, which is also used for energy and survival of the tissue, and also sugar exchange. As a secondary complication, excessive blood sugar and uncontrolled diabetes can also damage those nerves and cells because of all that blood sugar buildup, and that can affect memory long-term, put you at a greater risk for losing established memory, and prevent other formats of memory as well. Can we go to the next slide? So as we can see here, diabetes is going to relate to a bunch of negative health outcomes, which overall increase neurodegeneration. The excessive blood sugar is killing all those neurons and nerve cells, increasing the inflammatory response, which is also causing further degeneration, and impaired neuroplasticity. Neuroplasticity is our ability to form more memory, new thoughts, new behaviors, and overall increased cognition. It's done by increasing the communication between the nerve cells. And because of diabetes and the increased risk of Alzheimer's with diabetes and memory impairment, the plasticity will not be the same. And so we'll touch on this in our other slides as well. We can go to the next one now. So there's some research being done specifically on Alzheimer's disease and diabetes. But let's really break down Alzheimer's disease first. It's the most common form of our dementia. Alzheimer's disease specifically likes to reside or cause damage in the memory center called the hippocampus. That's where we store our long-term memories, and also responsible for storing our short-term memories. It can progress to affect behaviors, our speech and language, our ability to understand language as well. And it's a buildup of these proteins, these neurofibrillary tangles, and something called amyloid beta plaques. And specifically, diabetes and high blood sugar is very closely correlated and associated with these proteins and plaques here, as we're going to get into. And so as we dive into the next few slides, we're going to see that association and how diabetes, high blood sugar, insulin resistance overall, and a bad lifestyle or diet and exercise regimen can lead to the increased risk potentially for Alzheimer's disease. So we can go to the next slide now. So I really wanted to highlight this. Just because per se, a patient or someone you know, or you even yourself, is potentially linked hereditarily or from a genetic standpoint to Alzheimer's disease, that does not mean you are prone to get Alzheimer's disease. Alzheimer's disease comes from a combination of genetic, lifestyle, and environmental factors. And so specifically today, like we mentioned, we're focusing on sugar, but it also revolves around our exercise control and regimen, our stress levels, and a multitude of lifestyle and environmental factors. Can we go to the next slide, please? So this is a good depiction for our visual learners out there, what Alzheimer's disease looks like, specifically in a microsection of the brain. We can see all the plaque buildup around the healthy neurons and the ones that are damaged from this plaque buildup. The damaged ones also face this effect with high blood sugar. And so not only do they look bad, but their connection with the healthy neuron, as we can see below, isn't strong. And so those extensions, those finger-like extensions off the cell themselves, are weakened, and their connection with that healthy cell is also going to be weakened. And that goes back to what I was discussing with plasticity. Our ability to form new memory, continue to store new memory is impaired. You can go to the next slide. So a couple research studies set out to see the association between high blood sugar and specifically these proteins. The first one was a researcher by the name of Holter-Kater. So he said specifically, as a result of insulin signaling dysfunction, there's a lot of oxidative stress, high cholesterol, and these all together will accelerate the production, accumulation of something called amyloid B and tau proteins. And these are these proteins that we saw on the previous slide that were affecting these neurons. And these also play a major role in Alzheimer's disease. These proteins are responsible for increasing the progression and the prognosis of Alzheimer's disease. And as we can see here, insulin resistance or the insulin signaling dysfunction can lead to the increase of these proteins. Go to the next slide, please. So another researcher by the name of Mad said to say, these findings suggest the increase of prevalence in Alzheimer's disease and increase in those in diabetes are correlated. And the primary mechanism is by a diet that's high in blood sugar, carbohydrates, starches, sugars, in turn can inhibit the breakdown of these proteins as well. And so our take-home message here is that diabetics with insulin resistance, high blood sugar, inactivity, obesity, it can lead to the increased production of these proteins that causes and worsens the prognosis for Alzheimer's disease, as well as preventing the breakdown of them in general. And that's why typically we see a 60% increase in risk associated with diabetics for Alzheimer's disease.
Primarily. So I'm just going to talk a little bit about cholesterol in general and its connection in relation to diabetes for our webinar. So just a little picture there, a little bit of illustration there. You can go to the next slide. Just want to talk about what is cholesterol. It's a waxy, naturally occurring substance in the blood. The best way to think of it is fat. And normally we have a bit of a negative connotation when it comes to fat because, of course, we see how that affects things within the body. However, we do need some fat. So cholesterol is something that is actually produced by our liver, and it's used to build cells, make vitamins. It helps create some hormones. So it is a naturally occurring substance within our body that we do need. However, the problem becomes when we have too much of it, and that is usually going to come in the form of excess dietary intake. So when we're looking at cholesterol, is particularly from our side as PCP, we're mainly focused on a few different things here, starting with our two primary types that we look at, which is your LDL and your HDL. And these are referred to, typically, most people hear them as the bad and the good cholesterol. So LDL is your bad cholesterol, and what it does is it transports fat throughout your blood. And if you have too much of it, you will start to deposit that fat into your arteries all throughout your body. What we have on the other side is your HDL, which is your good cholesterol. And what that does is actually takes the fat away from the arteries back to the liver so that it can be recycled, reprocessed, and continued to be used for natural functions. We also have one other thing that we typically keep an eye on, which is our triglycerides. So that's another type of fatty acid chain. And this is typically coming from excess calories. So we intake calories every day to give us energy. If we have too many calories for what our body is needing to expend on a daily basis, that extra will be broken down and converted to triglycerides. And that's how we can get some extra elevation in that. And as I'll talk about a little bit later, that is one thing that is affected with diabetes, where we're intaking too many carbs and calories. So go to the next slide here. Just some risk factors for people to be aware of for when it comes to developing high cholesterol. There is, of course, a genetic predisposition here. So people who have mothers, fathers, grandparents, brothers, sisters, anyone in your family, especially a first degree relative who has a history of high cholesterol, heart disease, heart attack, stroke, those are all typically indicative of someone who has a history of high cholesterol. And we encourage those patients to get tested, usually a little bit earlier than what is normally recommended. Of course, an unhealthy high-fat diet, high-calorie diet, sedentary lifestyle, not doing enough exercise activity to burn those calories in fat, being obese, which naturally will come from a high-fat sedentary lifestyle. All those things can, of course, be controlled. Uncontrolled diabetes is something that also is affecting cholesterol. And then, of course, there's a few things that we can't necessarily control, but that we do look for in patients with high cholesterol, such as hypothyroidism, so an underactive thyroid gland, or in general, are men. Men are typically at higher risk of developing complications of high cholesterol and developing high cholesterol. So moving on to our diagnosis criteria. So this is something that we would be doing in the primary care office. We're going to be checking some screening blood work, checking what we call a lipid panel, and it's going to give us all of these numbers here: total cholesterol, LDL, HDL, and our triglycerides. So what we're looking for is what's called hyperlipidemia, and that's defined as any abnormal cholesterol level. So a total cholesterol of over 200. An LDL or bad cholesterol of over 100, triglycerides over 150, or an HDL less than 40 in men, less than 50 in women. So remember, we're trying to keep our overall cholesterol numbers low, but we want our HDL, good cholesterol, to actually be high. So moving on to our treatment guidelines. So if you come into our office, we do a lipid panel, we have some elevations in cholesterol. Well, next we move on to some criteria, which comes to us from the American Heart Association and the American Academy of Cardiology. So anyone aged 20 to 75 with an LDL above 190, we are recommended to start medication right away. Anyone who's 40 to 75 who has known diabetes, we will typically start medication right away. If you are under 40 with diabetes, then we will typically take into account some other risk factors such as high blood pressure, family history of heart disease, smoking. Those kinds of things is what helps drive our decision making, because those are all other risk factors for development of plaque buildup and heart disease. Then if you have a 40 to 75-year-old who does not have diabetes and an LDL between 70 to 189, that's where we again are using our risk factors to take into account whether or not we would want to start medication. So what I have listed here is what's called an intermediate risk score, and we determine that with something called the ASCVD risk calculator. And this is another tool that comes to us from the American Heart Association. Takes into account things such as your age, your sex, your race, what your cholesterol is currently, what your blood pressure is, if you're on medication for high blood pressure, and if you have a smoking history and or a current smoker. So putting all of that information in whenever I get a patient's labs, it will give me a percentage chance of somebody having some sort of cardiovascular related event, such as a heart attack or stroke, over a 10-year period. And what's considered to be intermediate risk is about 7.5% or higher. So usually when I have my discussions with patients about their cholesterol, I'll tell them that I put all this in, I ran their risk, and if they are above 7.5, we make a decision about starting medication. And the important thing to note here is that the reason that we have these guidelines and the reason that we make these determinations is because persistently elevated cholesterol levels will lead to plaque buildup in the blood vessels, which can lead to heart attack, stroke, and peripheral artery disease. So if you have a blockage in a heart blood vessel, that's how you can have a heart attack. If you have a blockage in, say, your carotid artery in your neck, if you can't get blood up to your brain, that's how you can have a stroke. And then we have peripheral artery disease, which is where you get blockages in your extremities, like your arms and more commonly your legs, where you will have pain due to lack of oxygen and blood flow in the vessels of your legs. So we talked a whole lot about when do we treat. This is going to answer how do we treat. So of course, at the end of the day, all of these problems, diabetes, cholesterol, high blood pressure, obesity, we always are preaching good diet and exercise. So 3 to 5 days a week, 30 minutes per session at minimum, for good cardiovascular exercise has been proven to reduce all of those things: cholesterol, diabetes, high blood pressure. And then I'll let Ern discuss a little bit about some of the dietary changes that can be made. But when it comes to initiating medication, the gold standard therapy for us are what are called the statins. And I'm sure a lot of people have heard of those. Some common examples: atorvastatin, rosuvastatin, simvastatin, pravastatin. Those are your Lipitors and your Crestors. We do have different intensities based on the type of medicine as well as the dosage, and we make that determination kind of, down the line as far as what kind of labs we're looking at. But these are really great medications. They work very well at reducing those cholesterol levels. Now, some people can't tolerate them. They do occasionally have some side effects that we do discuss during our visits. If they cannot, we move on to something like a Zetia or ezetimibe, which is a different class, is designed at targeting cholesterol, or something that we may switch in or add in addition is like a fenofibrate. And fibrates are good for triglyceride management in particular. For other people who cannot tolerate statins, we have a new class that is starting to hit the market and become a little bit more popular. They are called PCSK9 inhibitors. So these are biweekly injections. And the most common ones right now, we have our Repatha and Praluent. So these are some that we're starting to see a little bit in primary care. We're also seeing it used a little bit more with cardiologists who are managing people with resistant high cholesterol, those who can't tolerate the statins. And then if you're wondering some things that maybe you could do on your own before needing medication from us, there are supplements like omega-3 fish oil pills, red yeast rice, niacin. It is a good idea to discuss with your healthcare provider before starting these supplements, but just so you can be aware of some of the potential side effects and how they work. But omega-3s are pretty good for triglycerides that incorporate some healthy fats into your diet. Red yeast rice and niacin, both helpful for cholesterol. And then just moving on, so a little bit more information about cholesterol and its relation to diabetes. You are more likely to have high cholesterol if you are diabetic. Again, as I said, everything tends to go sort of hand in hand for a lot of our patients. An unhealthy lifestyle, including a high-fat, high-carb diet, sedentary lifestyle, low exercise, and an accumulation of excess body fat will typically lead to high blood pressure, high cholesterol, and diabetes. We also will typically see a little bit higher triglycerides in our diabetics, just because, again, due to the increased caloric intake, carbohydrate intake, and it does cause some insulin abnormalities, which makes it a little bit harder to break some of those triglycerides down. Another thing with diabetes that we will typically work with is that our goal LDL is typically going to be lower in diabetics. So usually our goal is to be under that 100 threshold for LDL. That's what's considered normal. If someone has high cholesterol to the point where we've put them on medicine, our goal is to get them under 100. However, for our diabetics who have any sort of increased risk of cardiovascular disease, meaning they are over 65, they're a smoker, they have high blood pressure, they have a family history of heart disease, heart attack, stroke, anything like that, then we typically will change the goal to be below 70. And that's why we are usually a little bit more aggressive when it comes to statin therapy and overall management in our diabetics. So once again, mainstay of treatment for all of this is lifestyle modification and risk factor reduction. If you have high blood pressure, we want to get that under control. If you are overweight, we of course would want to help you lose weight. We want to eat right. We want to get regular exercise. If you're a smoker, we encourage you to reduce or completely abstain from smoking. The goal of our clinic as primary care is about preventative medicine. Most people don't know that they have high cholesterol unless they get checked with a blood test. You will not notice that, my cholesterol feels high today. You will not have any symptoms of, discomfort or pain when you have high cholesterol until it gets to a point where you start to have blockages. And that's where we get concerned, where you can have a heart attack, a stroke. You'll have pain in your legs because when you get up and move around and you need more blood, you can't get it because of those blockages, and you will have pain from that. And by that point, you might need a procedure, you might need a stent, you might need something to be done that is a little bit more invasive. And so the goal for us is to reduce these risk factors, keep these levels low, and that is what will keep you living a healthier life for a much longer time period. So feel free, if you have anyone that needs to be seen, we do encourage everyone to come in for yearly physicals at the very least. Would love to get some baseline screening labs and look for these kinds of things. And if anyone has any questions, feel free to reach out to us.